Hey everybody, it's Professor Wells. This week we're going to go over Chapter 17, which is reviewing the polymers for prosthetic dentistry. Acrylic resins are used in the construction of complete and partial dentures, orthodontic retainers, and also maxillofacial prostheses. They're also used to make the maxillofacial prosthesis used to replace missing oral and facial structures. To review, polymer formation. Polymers are large, long-chain molecules formed by chemically joining together smaller molecules called monomers. When two or more different types of monomers join together, the polymer formed from them is called a copolymer. The act of forming polymers is called polymerization. When the side chains of adjacent polymers bond together, the polymers are then termed cross-linked polymers. There are two types of polymerization, addition and condensation. Addition is the most common form of polymerization for dental materials. It occurs in three different stages: initiation, propagation, and termination. Unlike condensation polymerization, the reaction does not produce any byproducts. Monomers have a core unit of two carbon atoms joined by a double bond. One carbon atom has two hydrogen atoms attached, and the other carbon atom has attached to one hydrogen atom and one reactive group called a free radical. The free radical is made reactive by the chemical reaction of organic peroxide with an activator or accelerator, or by heating. During initiation, the free radical initiates the reaction by opening the bond between the two carbon atoms of the monomer. The broken carbon bond causes the monomer to bond to another. Each linkage leaves a free radical available for further reaction. The process of linking monomer units is called propagation, and it continues until the monomer units are all used up. When the free radical is tied up or destroyed, the process is called termination. The materials that react by chemical means are called chemical curing, self-curing, or autopolymerizing. The materials that use heat to initiate the reaction are called heat-curing polymers. Materials in which the reaction is activated by light are called photo or light-cured. Condensation polymerization does not have many uses in dentistry, so we're not going to really go over that. Synthetic polymers used in prosthetic dentistry are called acrylic resins because they are derived from acrylic acid. Acrylic resin forms when a liquid monomer is mixed with a powder of small polymer beads. The mixture undergoes the polymerization process and is called polymethyl methicitrate, or PMMA. Acrylic resins are used for denture bases and teeth, relining and repair of prosthesis, provisional acrylic partial dentures, custom trays, and tissue conditioners. Acrylic resins are useful because they can be shaped to any contour, and they can be custom colored to match the shade of teeth, gingiva, or skin. They are often used in dentistry and are modified by the addition of plasticizers, rubbers, and fillers to change their physical properties. Plasticizers are liquids added to soften the acrylic plastics and make them more pliable. Rubbers may be added to increase the impact fracture resistance of the acrylic resin, and fillers are added to strengthen the resin or change its optical properties. Polymers undergo shrinkage as a result of the polymerization process and can shrink about 6% by volume. Sources of dimensional change in addition to polymerization shrinkage include water sorption and thermal expansion. A denture base will increase in overall size slightly when it absorbs water. This expansion may help offset some of the shrinkage that occurs during polymerization. The coefficient of thermal expansion is twice the rate of composite resins. The strength of acrylic resins is fairly low. Acrylic resins are not very hard materials, so they are subject to wear. They will break if they're dropped. Denture bases do not conduct temperature well. Because the denture partially insulates against the temperature of the food or drink, patients may burn themselves. The type of processing has some effect on the properties. Polymerization is never 100% complete, and varying amounts of free monomer may be present in the polymerized material. Generally, chemical cured acrylics are weaker, softer, more porous, and less color stable than heat cured resins. After polymerization, there is more residual monomer in the chemical cured resin, and it initially adversely affects many of the physical and mechanical properties until the monomer leaches out over several days. The tissue of some patients react to this residual monomer and become inflamed. Heat-cured acrylic resins are harder, stronger, and less porous, and have less than 1% residual monomer that leaches out relatively quickly. Porosity in the acrylic weakens it and makes it prone to collect debris and microorganisms. This is a result of loss of monomer or inadequate pressure during processing. It can also happen by the entrapment of air during mixing of the powder and liquid acrylic components. Denture odor and stains develop more readily. Sensitive patients can react to the components of the denture materials. If excessive free monomer is present, some patients' tissue may become irritated or inflamed by the methicide crate monomer. Dental personnel can even develop contact dermatitis through repeated exposure of unprotected skin to the materials. The primary function of the acrylic resin denture base is to retain the artificial teeth in the prosthesis. It also serves to distribute forces of mastication over a wide area so as to reduce pressure on the ridges that might contribute to resorption of the underlying bone. Acrylic material can also replace missing intraoral tissue. Acrylic resins polymerize through an addition reaction and are supplied as a powder or a liquid. Inorganic pigments are added to give acrylic resin colors resembling oral mucosa, and titanium dioxide is added to keep the acrylic from becoming too transparent. The first stage seen when the polymer and the monomer are mixed is called the sandy stage because the mixture looks grainy, similar to sand and water, and has a runny consistency. The second stage occurs when powder particles absorb the liquid through their surface. This is called the stringy stage because the mixture is stringy when handled and is thicker in consistency. In the third stage, called the dough stage, more of the powder goes into the solution, and the mixture changes from stringy to doughy and is more easily manipulated. In the fourth and final stage, called the rubber stage, the mixture has a rubbery consistency that no longer can be manipulated to form the denture base. Polymerization of chemical cured acrylic resins is set into action when the tertiary amine in the liquid activates the benzoyl peroxide and the powder to produce free radicals. The hydroquinone initially inhibits the reaction from progressing by destroying the free radicals and increases working time so that the materials can be manipulated for a reasonable period of time. The most common method of processing denture bases uses heat and pressure during polymerization of the acrylic resin. Heat-cured acrylic resins go through initial stages of polymerization that are similar to those of chemical cured. The special monomer liquid is used in place of regular monomer, and less porosity is found using the microwave oven processing method. Processing is completed in about 5 minutes instead of the several hours needed for the heat processing. Some vinyl acrylic resins can be processed by injecting the material into a mold when it's in the doughy form. This is done in some labs because it's faster than the traditional heat processing. In addition to heat and chemical curing, dental resins can be light cured. Light cured materials are fast and easy to use, but require the purchase of a light curing unit. Complete and partial dentures sometimes have a soft lining material placed on the tissue-bearing surface of the denture base. Soft liners may be used as short-term treatment for a few days up to a few weeks to allow tissues to heal following surgery. Soft liners also may be used for long-term treatment for patients who have chronic soreness with hard denture bases. Long-term soft liners are made from silicone rubber or acrylics and may be processed at room temperature or with the application of heat. Short-term soft liners are referred to as tissue conditioners or treatment liners and are usually placed chairside. With that being said, there are many patients that will get a soft reline on their denture and then they never come back. And then when they do come back, it's because they have a sore spot And when they hand you their denture, that soft reline material is still there, but it's basically brown, discolored. It smells, it's pretty grody. You guys will see this, especially when you get hygiene patients that they may have a full upper denture, but still have their lower teeth. It's more common than not. You can actually buy some sort of soft reline material over the counter. I've had a couple patients use this and then bring in their denture to have me clean it, and I don't even want to begin to describe what it looks like. So just a couple things to keep in mind. I think I might try to find a picture. I think I may have one on my phone to post for you guys to show you what it looks like. I will give you fair warning if and when I do. Dentures become loose over time as the alveolar bone of the ridges resorb. These loose dentures often can be made to fit well again by a placement of a lining material to fill the space. The most common material used for this purpose is an acrylic resin similar to the original denture base material. With the chairside technique, a chemical cured acrylic resin supplied as polymer powder and liquid monomer is commonly used. First, an acrylic burr is used to remove a thin layer of the tissue-bearing surface on the denture. New material is placed and the denture is reseated. This position is held until the material just begins to harden. The lab reline uses an indirect technique in which an impression of the tissue is made inside the existing denture and a cast is made from this impression. Proper infection control procedures should be followed when a denture is transported to the lab and when it's received from the lab and delivered to the patient. Patients may not receive professional advice on the use and care of over-the-counter liners and often use the liners far beyond their useful life. Remember what I said earlier? These materials can stiffen and cause damage to these tissues, especially if occlusion is not reestablished with the new lining in place. They promote the growth of fungi and the patient can end up with infection. There are 3 types of denture teeth used. Plastic or acrylic resin, composite resin, and porcelain teeth are used for complete and partial dentures. Each has certain advantages and disadvantages. The majority of denture teeth used for removable dental prosthesis are made from acrylic resin. Acrylic teeth are tough and chemically bond to the acrylic base of the denture. They're easy to adjust, reshape, and polish. Composite resin teeth have a more natural appearance and translucency. Porcelain teeth are brittle, hard, and highly resistant to wear. They're not indicated for use against the natural teeth because they are very abrasive and transmit heavier occlusal forces. So if you look at this picture, this patient has a maxillary denture with porcelain teeth, and they have excessively worn down their opposing natural teeth. It almost looks like those teeth have been prepped for crowns, but they haven't. A specialized aspect of prosthetic practice may include the fabrication of maxillofacial prosthesis to replace facial tissues lost as the result of trauma, disease, surgery, or birth defects. Materials that have been used are synthetic latex, plasticized vinyl resins, and silicone rubbers. And this figure is kind of cool. I've never seen anything like this. I actually am not quite sure what I would do if I did. But this is a flexible acrylic prosthesis for a nose that she had lost to cancer. Acrylic complete and partial dentures can be repaired rather easily when they're broken. The repair of a partial denture with a metal framework is more complex depending on the location of the break. The broken denture should be disinfected at chairside before it's transported to the lab. Super glue should not be used on these if it's broken. You will be surprised how many times you get patients that think super glue is what's going to fix things in their mouth. I actually just had a patient today who chipped the mesiolingual cusp of tooth number 30, and she took super glue and glued it right back in and then came to the office to see if we could use dental cement to glue it back in so it doesn't come off. So we had to explain to her that super glue is toxic. It's not meant to go in your mouth. and that just cementing the piece of broken tooth back on isn't going to save it long term. So what we did for the patient was that we did cement the piece back on until she was able to come back in next week when we would have more time for her. Another super glue story I will tell you is I had a patient come in who had an anterior bridge from, it was I think 6 to 11. She had it for over 10 years. Crowns and bridges are only meant to last about 10 years. If they're taken care of properly, they'll last longer. She didn't take care of hers. She came in because she said that she couldn't cement it in herself any longer. So she hands me well, it did not look like a bridge at all. It looked like a block of cement. And I asked her what she was using to cement this in with. She said super glue. So I lift her lip and I look at her tissue and it is just gray because the glue had burned her tissue so badly. And I just kind of set that bridge down on the counter and I walked out of the room and I got my boss and I told him, you need to get in there now. It took a lot of patient education to get her to understand that that's not how we fix things in the dental field. So we have replaced that bridge. It looks beautiful. She comes in every 3 months for her hygiene appointments. So it looks a lot better, but just thought I'd share that with you guys. Okay, where was I? Okay, so light-cured demithycrates have a number of useful applications, including repair of broken acrylic prosthesis and fabrication of custom trays and record bases. So, no super glue. Similar to other chemical cured acrylics, custom tray materials are supplied as a powder and a liquid. The powder and the liquid are mixed, and when the mixture reaches the dough stage, the material is adapted over the tissue portion of the cast by hand to a uniform thickness. Record bases are rigid bases that correspond roughly to the denture base. They are used in the construction stage of the denture and have wax rims added to them over the ridge areas. The technique for making custom trays and record bases for light cured I can't pronounce this word, guys, dimethyl citrates is the same as for the chemical cured materials, except instead of mixing powder and liquid, a sheet of the preformed material is removed from its light-proof package and adapted over the cast or wax spacer. Trying to adjust acrylic prosthesis can become a frustrating experience if patients do not know what to expect from their new dentures. Dentures may create a feeling of fullness to the mouth as you adapt to the additional thickness of the denture. Most people have some difficulty pronouncing words, especially those with F's and the S sounds. The biting force with dentures is about 20% of what natural teeth have, and they sit on top of tissues that are compressible, so there will be some movement of the dentures while eating. Saliva is important to help swallow, lubricate mouth tissues, and help form a seal with dentures. The mouth will react to the presence of a new denture by producing more saliva than usual. Upper dentures form a seal in the palate, while a lower denture is looser, and the patient will need to position their tongue to keep the lower denture seated. Dentures can rub sore spots, and cheek biting is not unusual either. The patient should never attempt to adjust their own denture. This is another big one, especially in men, because they have Dremels at home and they feel they can use their Dremel to fix it. I've had that happen. You'll be surprised what you see. If the teeth were recently extracted, the alveolar bone and tissues will shrink with healing and the denture will become loose over time. Regular dental checkups are required to check for oral cancer and to ensure that the denture is serving the patient well. So when I said that the alveolar bone and tissues shrink with healing after teeth are extracted, so with that process, what happens is that they will do a full mouth extraction. Let's say they don't have all of their teeth, they've already lost some of their teeth. So they do a full mouth extraction and they immediately place that denture. That's called an immediate denture. So when they place that denture immediately after those extractions, what it's doing is acting like a Band-Aid. So that helps prevent the tissues from swelling, and it helps the tissues form to the inside of the denture. So the patient will come back in about a week and we'll take it out, we'll clean it for them, we'll check the extraction sites, see how everything's healing. And then we give it back to them, and then they're instructed to take it out at nighttime and begin the regular wear of it. And that's usually when they start developing sore spots. So sore spots just leaves like a little ulcerated tissue where the denture is hitting the tissue harder in certain areas than other areas. And this is why it gets frustrating, is because they come in, you adjust the sore spot, everything feels fine, and then they'll come in a week later and they have a sore spot in a different area. So it takes a couple appointments for the denture to get exactly where it needs to be. The patient should clean the tissue surfaces and the teeth and outer surfaces of the denture with a denture brush. The dental hygienist can provide a service by removing the calculus before returning the prosthesis to the patient. Yes, you can get calculus on dentures. Calculus can be removed by placing the prosthesis in a denture cleaning solution inside a zippered bag placed into an ultrasonic cleaner. Acrylic resin prostheses absorb water and are sensitive to water loss. The patient should be instructed to keep their denture wet during periods of storage. This will prevent dimensional changes and distortion that can affect the fit. Acrylic resins are versatile materials that can be used to replace missing oral structures. The ability of these resins to chemically bond to one another is important when plastic teeth are linked to the denture base or when they're relined or repaired. When properly handled, they're strong and durable. So if you guys have any questions or even any stories you want to share, feel free to email me hwells14@ivytech.edu.